Hello, everyone, and good afternoon from Dubai. Is my audio clear? Am I audible to you?
Yes, Ricky, you are. I can
Thank
hear
you.
you.
Welcome to our 77th live webinar. My name is Ricky, and I am delighted to be here with you alongside the TDCC training team. We are excited to bring you another interesting topic today: reflexes and neurodevelopment. How occupational therapy supports neurodivergent children. On behalf of TDCC, we would like to thank our 97 advocates from 12 countries who registered for this session. To those who have joined us live here and on YouTube, thank you for your time and presence. We would like to acknowledge our registrant from Algeria, Australia, Egypt, India, Iraq, Kuwait, Lebanon, Pakistan, Philippines, Qatar, United Kingdom, and UAE. So, wherever you are in the world, good morning, good afternoon, and good evening. But before we begin, let me share a short video about TDCC and our esteemed speaker for today. Thank you.
Welcome to the TDCC Community Live webinar.
TDCC stands for the Developing Child Center located in Dubai and Abu Dhabi, UAE.
Established in 2012. We have been providing personalized support to over 1,000 children. We have 60 dedicated and committed experts, and we work closely with parents and schools to ensure no child is left behind. We think different, we teach different. We empower, not limit children. Labels like autism, dyslexia, and ADHD are not relevant or perceived as disabilities, difficulties, or disorders that limit children's abilities. We believe that brilliance needs difference. The TDCC services are available in English, French and Arabic. The inclusive educational services nurture and support the developmental and educational needs and help empower each child to reach their full potential. Occupational therapy assists children in performing and achieving important learning and developmental skills they need in life. Psychomotor therapy is a healthcare profession that is based on a holistic view of the person and is involved in the treatment of different disorders. Speech and language therapy assists children who have disorders of speech, language, communication, and swallowing. Psychology provides both educational and clinical services, including counseling and parenting. ABA therapy focuses on improving specific behaviors. It is commonly practiced as a therapeutic intervention for individuals with autism. Specialist learning support. We assist in developing the academic and social development of students who need support in all these areas. And we design and host local and international training and workshops for practitioners, parents, caregivers, and educators. Just like this one today. We have a few rules to follow during the webinar. Please remain muted while the speaker is presenting. Please give your full attention to the presentation. We will be sending you the replay, so you can review it anytime. Please be interactive if the speaker requests your participation. During the question and answer session, we kindly request everyone to type their questions in the chat box and the speaker will address them.
Welcome to the 77th TDCC webinar Primitive Reflexes and Neurodevelopment, How Occupational Therapy Supports Neurodivergent Children. We are honored to have Dr. Raghida Achkar, Head of Occupational Therapy Arabic Services. With over 20 years of clinical experience, Dr. Raghida is a highly accomplished neuropediatric occupational therapist holding a professional doctorate and a PhD in neuro-occupational therapy. Certified in primitive reflex integration and neurofeedback-related approaches, she brings deep expertise in neurodevelopment, early intervention, motor rehabilitation, and school-based therapies. Fluent in Arabic, English, and French, Dr. Raghida is known for her evidence-based, family-centered approach to empowering children and supporting meaningful developmental progress. We are also pleased to welcome Emmy Priskila, occupational therapist at TDCC. With 5 years of clinical experience, Emmy brings strong expertise in pediatric skill development, early intervention, and mental health support across diverse age groups. She holds a bachelor's degree in occupational therapy and has completed advanced training in autism interventions, cognitive rehabilitation, occupational therapy management in cerebral palsy, mental health practice, and neurocognitive disorders. Emmy is known for her holistic, evidence-based approach, focusing on comprehensive assessment, functional goal setting, and empowering children and families to achieve meaningful progress. Ladies and gentlemen, let's all welcome our esteemed speakers today, Dr. Raghida and Emmy.
Good morning, everyone. We will start to dig in our subjects that we really love and we share in our OT department. Let me start by a question. Have you ever wondered why some children struggle to sit still, focus, or manage their emotions, even when they are trying to do their best? Often the answer is not behavioral, it's neurological. Primitive reflexes are automatic movement patterns that develop in early infancy. They are meant to integrate as the brain matures, but when they persist, they can quietly interfere with daily life. As occupational therapists, we look beyond the behavior and ask, what is the nervous system telling us? Today, we will explore how reflex integration can transform a child's participation, confidence, and functional independence. When reflex may remain retained or insufficient integrated, we may observe challenges in behavior, sensory processing, motor planning, or academic performance. Today, Amy and me, we will discuss how understanding reflex patterns allow us to better support children in their everyday environment, at home, at school, and in social settings. We will let Amy to discover this path with you. Feel free to add question and your experience, and we will be there to be with you. Thank you.
Yeah, it's a pleasure to welcome you all today with a webinar on this primitive reflex. We have been delighted to have such a diverse group of participants joining us. So, primitive reflex plays a foundational role in early development and can have a lasting impact on learning behaviors and the movement. And also, it plays a vital role in a day to day activity of living and day to day activity of a child. So, let us go move on to the topic. Yeah. So our topic is primitive reflex and neurodevelopment. How an occupational therapy supports neurodivergent children.
One minute, you have a technical problem. Just to move it.
Yeah.
Okay.
Yeah. So what's a primitive reflex? Sorry for all the audience for the small technical error. So let us continue with what's a primitive reflex? So usually a primitive reflex is present with a survival and is also an involuntary movement that patterns are being designed to keep the newborn alive, and it also plays a vital role in the development of a child. And it's an automatic stereotyped movement, and it's being directed from the brain stem and being excluded without the cortical involvement system. And also the primitive reflex, it makes an intentional movements pattern, and it keeps the higher level of the learning and to the development of the childhood. So usually what's if a primitive reflex do not integrate? So what's the negative part of that? So each primitive reflex set a movement, and it's like a unique developmental milestone of each individual kids that we have been working on. So if a primitive specific reflex is retained, like it has a specific area of a development, for example, in back we will be working with a reflex, and you will be learning a lot of reflexes. And how does if the reflex is not being integrated, how does it affects the functional? For example, it affects the fine motor, it's going to affect the balance, the movement, the gross motors, and it also plays a vital role in the academics. And additionally, many reflexes being like directly related to one another. Every reflex is an interrelation to one another. It's not like a specific reflex. For example, if one reflex is not being going to work up, it's okay, it's been like trained up with one, but it's an interlinked, it's co-handed. So we need to work like in a co-hand joint working. So, and it's an indication of the structural weakness or an immaturity within the CNS system, which is known as the central nervous system. And it's also make a developmental abnormal movement pattern. For example, it affects the crawling, rolling, or the walking, the locomotory system. So it's in like a hierarchical pathway. So when a children's like retain the primitive reflex, they often struggles with, usually they struggles with the social skills, the coordination of playing games and the sports, emotional regulations. So sometimes they be happy, sometimes they can be sad, and sometimes they can be anxious, and problem solving skills. So it also affects the cognitive subdomains or the executive domains of the cognitive factors, focusing in the class readings and writings, and also it leads to anxiety. So, what causes a primitive reflex to not integrate? So, we need to see this journey from the birthhood, from the mother. So, it starts from the womb. So, it works of the mother's lifestyle, environmental modifications, or the day to day lifestyles, or it can be some radiations, or it can be due to some conceived as results of the IVF or the stress, or it's due to overall environmental and the day to day living of the child. And then a premature birth, if it's not, the child is not going to be a full term, and if it leads to a premature birth, it also leads to the some reflex delays, and also the induced labor, c-sections, or a trauma during the birth. And what happens after the birth? So it's going to be like prolonged jaundice, or problem with feeding within the first 6 months of the life, or the low birth weight, or it's due to some developmental motor delays. And infancy and the toddlerhood. So it can be torticollis or tongue tightness, or cerebral palsy CP, or a Down syndrome, and it can be like TBI, epilepsy, and autism. And then when a primitive reflex are not integrated, children can have an impaired fine and a gross skills, and impaired balances, anxiety, or they may have overreactions to the environment. They can have a learning disability like dyspraxia, or dyslexias, or dysgraphia. So these kinds of they can have a problems and sensory processing difficulties. So here I am going to just brush up the first 8 basics primitive reflexes that is being like have an impact on the of the childhood, like reflexes are not being integrated. So what are the problems that makes the child to get delay on the day-to-day activity of life? So first we are going to like just to have a small brief note on moro reflex. So moro reflex is nothing but it's a constant flight or a flight mode. It's a stimulus that stimulate off an adrenaline to the cortisol. These neurotransmitters works on the stress hormones, and also they affects the child's like motion sickness, or it's going to be high end coordinations and poor balances, and also the body immune system. And then it's TLR, it's tonic labyrinthine reflex. So this works on the postural reflexes, or like a low muscle tone, hypertonia, or also it works on the poor balances coordination. Like as I earlier told you that each reflex has its own interlinked with one another. Nothing is being like separated apart, but they are being interchanged with one another. And then ATNR plays a vital role in each kid, so that especially the kids, the parents, like who sends all the childs to their schools, from they can get receives the academics problems or complaints from the teachers. So the major reflex that need to be worked on is ATNR. So ATNR is like it has the poor ability to cross the midline and discriminate between right and the left. So we have a neurological term like dysdialokinesia, where the child have unable to recognize which is the right side or which is the left side, or the pathway right and left. So they have a confusion over the right and left. And also it deals with the visual perceptual skills and oculomotor, poor handwriting. And then it's STNR. So STNR works with the gravity, like locomotions of poor postures, and also the W setting. Many parents would have been, you have been like observed the child as being like sitting in a W setup. So sometimes why the therapist or the other professional doesn't want the child to sit in W sitting is because they lose the trunk stability, and also when they grow up the weight transmission on the lower extremity it affects, and also it affects their lower extremity locomotion pathways. And then what is the spinal gallant reflex? So this reflex is works on the back. So it touches with the lumbar regions, and also, and this leads to kennel fidgeting or difficulty in sitting. So example, you might see like lack of sitting tolerance over this, and toilet training, and also poor concentration and short-term memory. So it also works with the cognitive subdomains. And palmar grasp reflex. So palmar grasp reflex is like in when the child is being like in the first 10 months, the grasp that needs to be like developed is a pincer grasp where a thumb and an index needs to work on so the child can hold this. So when this reflex is not is going to be like integrated, the other reflexes like palmar supinated grasp or the digital pronated grasp or the quadrupod grasp or tripod grasp, the next level, the hierarchy level cannot be achieved. So palmar grasp reflexes need to be like integrated, then like working on the dexterity or hand function rehabilitation needs to be done over here. And then Lonier reflex is like it works on the vestibular processings and the posture. So how come this all reflex is being like interchanged with one another, and also the emotional regulation. Next is the rooting reflex. So this rooting reflex it works on like the food, like how the child's like need to be like intake the food, like swallowing and the selections of the food. And also you might many parents have like gone through the tongue tightness of the children's and the survival like of taking the food, and this kinds of swallowing deficits it's been like occurring in this rooting reflex. So now, what is the goal of primitive reflex integration? So this is the major thing. As an OT, we majorly focus on the activity of daily living. Daily living, making the child to be independent is the attached core and the aim of an OT. And the OT will reaches the any core or they reach to any limits to make the child to become an independent. So here the major goals of primitive reflex is that to make them independent in their daily living, and also we work on the bottom up approach so that we can see the productivity of the child in a short term period of time. And also and meditating of the levels of brain stems and the postural reflexes control from the midbrains. So these parts of the brain has the different functions like frontal lobes or the parietal lobes or the temporal lobes or the midbrain or the pons. So each of the brain parts have a different functions that needs to be worked with a child's day-to-day needs or make them to be independent. And also we need to set a base for the foundational skills. And the abnormal or the retained primitive reflex systems, like it can be lead to the learning disabilities or ADD, like attentional deficit disorders, like that. And then, so now let me go little bit interior of five major primitive reflex that everyone, every parents or every professional that goes through on. So the first one is going to be the Moro reflex. So Moro reflex is nothing but when you see this image, it's where like we can see that a child is being put into a tough situation of make the child to go down. So what happens like suddenly when the child gets that without a protectiveness response, so due to the protective response what happened, the child upper extremity, the hands goes into the extension position and the legs comes into the flexion of position. So what's a Moro reflex tells us, it's an involuntary movement and it's also a sudden stimuli. And also this Moro reflex as an interlinked with the auditory responses and auditory uh, response, like how when a child is being like put into this kind of situation, suddenly it becomes a stressful and then the child starts to cry. So what happens, they been collaborated with the stress and also the auditory response. It's like a physical response and the auditory response that's together. And also it's connected with the FPR, it's a fear of paralysis reflexes, and the motor emerges as an FPR. And then so the motor reflex is seen in the action, like it has a timeline, like how it needs to be like developed, because this motor reflex plays a vital role in the head control. So if it's going to be get delayed up for the child, it's take time for the child to get the proper head control. And then the symptoms of potentially retained motor reflex, for example, like it's a motion sickness or decreased eye contact, light and sound sensitivity, and it affects the body immune system, anxiety, and mood swings, and also it affects the high-end coordination in the sports. For example, like it can be like of indoor games or outdoor games of like a football, volleyball, throw ball, basketball, or it can be like a chess, anything. The major thing is going to be like a high end coordination. And then, so the Moro reflects the major functional activities that have making the child to sit in a therapy ball and then gradually like moving the child to from a one end to the other end. So when the therapist like moving the child to the one part of the edge of the head, suddenly the child promotes a protective response like that. They extend the upper extremity so that it develops the Moro reflex and it starts integrating it. And then the next one is tonic labyrinthine reflex TLR. So this works. This is an infant and it's a newfound challenges of gravity, and it also works in the muscle tone. So what it coordinates with the front and back of the body, and also it's responsible for the muscle tone and head writing, vestibular, and the proprioceptive skills. So what's happened in the TLR in the action? So in this image has been like given up. So in the first image, the child is when the neck is like flexed. So what happened? The arms and the leg, it's been like flexed, and it's curled up into the body. And then when the neck is being like extended, so it's like when the extended the both the upper extremity and the lower extremity start in an extension position like that, the child's like open up. When the neck is being flexed up, so the both the upper extremity and the lower extremity flex and it curls up. So this is the it can be in the action, and this is the timeline like it's need to be worked and begin be integrated and within the 3 months, because when there is no head control, the child cannot have a proper neck flexion or a neck extension. And what is the symptom of potentially retained TLR? It's a challenging with crawling, poor posture, they have low muscle tones, visual challenges, auditory processing challenges, and poor sense of space, time, and organization, like the orientation skills will be affected, and challenges with the sports. So the main TLR functional activity is that it's a prone ball bounce or fall catching, like how, for example, when a child is being put it up in this prone position and make him or she to be like holding this ball. So the neck control, it starts in a hierarchical term from the neck to the trunk to the pelvic and to the lower extremity. So all it works in the hierarchical junction. So this kinds of activity make them more functionally independent. And the next, the major one and the hero of all the reflex is going to be ATNR. ATNR is as asymmetrical tonic neck reflex. So when this posture, when you see this image, so when the stimulus is going to be like this, when the child moves the head towards the one side, the side where the head is faces, it's going to be in the extension position, like how the image is being showing, and the leg part also will be like extended, and the opposite side of the head will be in the flexion position, and also the leg is going to be flexed. So ATNR plays a vital role in an academic. And then it's a as I explained, like assisting with unscrewing down with the birth canals, and it's also like connected directly with the vestibular system and the balances and all the muscle tones. So this is the ATNR in the action, like when a therapist like they give the stimulus. So this happens with a kid. And then so it's like developed approximately in the 18 week, and also it's need to be like fully developed by the birth, and it's also like have a connection with Moro and the palmar grasp reflexes also need to be get integrated. So the symptoms of potentially retained ATNR is challenges with they have a crawling challenges, and they have challenges in poor like handwriting and visual tracking and establishment of the hand dominance after the age of 7. So all like dysdyliokinesias, like having confusions in right left discrimination, and also like sitting and postures and the balance, and these all falls in ATNR. So all this academic problems needs to work with this ATNR reflex. So when the child is given this supine board hole, so it's been like integrated the ATNR reflex. And then is the STNR. So STNR is a symmetrical tonic neck reflex, like the image tells us it's like symmetrical tonic neck reflex with a quadrupod. And then it's present until after the birth, and this tonic neck reflex has a connection with this STNR. And also, this STNR takes a very short time, just to 2 to 3 months of integrating. That's because the infant will move from the prone to the quadruped, from the prone position to all the both the upper extremity and the lower extremity comes into the quadruped position, so the child can start crawling up, and then a rocking. So a rocking is an inhibitory stimulation. So especially like it is an inhibitory stimulation, it works with slow and rhythmic vestibulars. So rocking plays a vital role. Also, it calms the nervous system and decrease the muscle tones, reduce the hyperactivities, and helps in relaxation and the sleeping. So when the stimulation is being given in a rocking position, so the STNR will be like integrated. And this Indian action, like how the child is being like four in a quadruped position, and a gentle rocking can be like induced into the child. And also in this you can see the small baby girl, like how her head looks down, so it flex, and the legs get extended and it be straightened, and her arms also like bend flex, and the upper body drops to the floor. So rocking on the knee in the quadruped position helps to like fully integrate the STNR. So the best way of integrating STNR is in a rocking. It's an inhibitory stimulus that helps the vestibular system to be in the action. And so that the crawling will be developed. And also this timeline, like it's been interlinked with TLR and the STNRs. And also it does works with more difficult, like it also works with the trunks and the pelvis and the lower extremity, the upper extremity. So it goes on the hierarchical pathway. So what's the symptoms of potentially retained STNR? It's like challenges. They have a challenges with the crawling, like low muscle tones, W sitting, especially clumsiness. So when the child is being in W sitting for long more time, it's need to be like integrated with an STNR. So this STNR plays a vital role so that the child can integrate. And so because W sitting, it's not been accepted, so later when the child is being growing, they cannot have the proper pelvic stability and the weight transmission, and it also affects the gait and the walking pattern. And also they have difficulties in reading and writing. So this is the STNR functional activity. We can give the child the downward dog to the cobra activity. So this integrates them with a neck stability, trunk stability, pelvis, and the lower extremities. So next is the spinal gallant reflex. So spinal gallant reflex, as the image is being seen, so it works with the back and the lumbar region. So it hits the lumbar region, and it's triggered by the stimuli to the back. And it's also needs to be contributed with the inner ears, and being like with the balance of hearing. And and this spinal gallant reflex have a connection with an ATNR, which plays a vital role in the birth processes. So the child needs to be stimulated in the lumbar region, lower back, which causes the movement in the hip, thus helping the baby move down from the birth canal. And also it contributes the range of motion. So when we have like every human has a particular range of motion, that RMO, that the range of motion works like for the shoulders, for the extension, for the flexions, for the pelvics, or for the plantar flexion. So we have different part for each ranges for the range of motion. So when that is not being achieved, it will be like compensated to the next part of the body. And so that to avoid that, we need to keep on integrating on that. So the spinal gallant in the action, like when the child is being placed up and the stimuli is on the back, so that it can be stroking, the gentle stroking can be provided on the spine, and they will be like lying on the stomach, facilitating the hip movement so that away from the stimuli, so that they can be like move on to the quadruped into the fourth. Now the timeline of this spinal gallant is developed in the utero, so it can be developed across approximately like 20 weeks. And like the spinal gallant reflex is have an interlinked with the ATNR, and it's been like facilitated for the crawling and also the hip movement. So it provides from stability from the pelvis to the lower extremity, so that the child can walk and they can provide the proper balance and proper gait. And the symptoms of like the potential retained spinal gallant is that they have the challenges in the milestone such as like rolling. So when there is no rolling, the next stage is will be like affected. And then also it affects the gait, the natural walking pattern. Instead of that, they can have the quadling gait or the different gaits, the scissoring gait, so that it affects the patterns, and it like the patterns will be like affected, and it also leads to the scoliosis. And also like they will be having difficulties in the cognitive parts of subdomains like attention, concentration, memory, and also sitting tolerances. So many ADHD kids are being like lacking like in the sitting tolerances. They want to move from one place to another, so sometimes they need a stimulation of the spinal gallant reflexes. And also the bedwetting beyond the ages. So bedwetting is like known as the nocturnal diuresis or nocturnal enuresis. Either they can have the bedwetting in the morning or at the night time. So this also needs to be like worked up with the spinal gallant reflexes. And tactile hypersensitivity. Tactile hypersensitivity also it leads with SPD. It's a sensory processing disorder, where for tactile hypersensitivity we need to work for the child with a deep pressure activity and brushing protocol or Wilberg protocol, gradual textures, exposures to the child like desensitizations, introducing them gradually from one material to the other, not making them into the flooding like techniques, like making them to observe all the textures at the same time. Rather, we can give them the desensitizations, and the proprioceptive heavy works can be done, so that this tactile sensitivity can be like reduced. And also we can give the clothing strategy for the children. For example, you can remove the tags and use a seamless socks, and you can choose the soft cotton fabric. Sometimes it is better that we can give preference to the kids to choose what fabric they need, rather instead of we forcing them to choose what they want. And then the spinal gallon functional activity is like heel reaches. Like this kind of activity gives them the functional way of improvement or productivity in the spinal gallon functional activity of the heel reaches. So what is the approach usually an OT works on? And I know that I'm really like it's a more of clinical based, and it's need to be like understand from the hierarchical hood from one by one, so that when we touch the topic of primitive reflex, it's need to be like come from the basis, so that as parents or as a professionals or from the other multidisciplinary team members, like we can know what is the base or what is the foundation. So when we know the foundation, like what's happening to the kids through the reflexes, and then we can work with different kinds of intervention. Without knowing the deep cause what's happening to them, we cannot apply the intervention. Rather it may go into a disadvantage, or it may leave the child into like emotional barrier which they cannot be like achieve into the particular situations. So now as an OTs, like we work with the approaches like rhythmic movement training, RMT, and neurodevelopmental therapy, NDT, occupational therapy with sensory integrations, and brain gyms and reflexes with the specific activities. Yes, brain gyms plays a vital role because it works on the both the hemisphere, the right and the left hemispheres of the brains, and it also works for the particular functional activities, because each like frontal lobes as learning or languages, like it has a different, and also like parietal, temporal, each one has a different unique function. So brain gyms works a lot. So as an OT we give a more creative activities, we use the approaches, but we will be like holistic and dimensional to see and to bring out productivity in the children's. So what is the major standardized assessment? It's we does an Buchan's orchestra test of motor proficiencies or Peabody developmental motor scale. And other than this, we have a non-standardized tools also. For example, to like analyze and like integrate what level the child is been like going on. Either it's been like for example, to tell on a scale of 0 to 4, like how the child is being like integrated, either it's been integrated into the mild or moderate or severe, or it's been in a good rate. So we have that kind of assessments to work with that, so that we know like this ATNR has been in this category and this STNR is this routing reflex in like this stages. So we have a non-standardized tools also. And then so here we have the ATNR integration activities, because the major goal of ATNR, it's like gross body coordination. That's the major thing. The main thing is like cross crawl. So cross call is like when it works on the dysdialokinesia, like right understanding the right left part, and also this kind of activity of touching the right hand to the left leg, it works on the midline crossing of activity, and also the bilateral coordinations. So when the child does that, the both the brain hemisphere works a lot, and also the infinity 8, when the infinity 8 is being drawn on the both the side, so either on the right side and also after the left side, or with both the hands together. So this bilateral coordinations works a lot, so that the both the functional involvement that is being like given up on the right brain and the left brain works together. And also inside like rolling crawling through the tunnels, so this works a lot, so that the child knows how to work on that, so that the both bodies like lower extremities and the upper extremity will be in the quadricep position, and then they crawl a lot. So these are the functional activity will help them to be like integrated in ATNR. And also in Moro reflects the integration activities, like the major goal of this, it's going to be emotional regulation, because as I told explained to you earlier, it works on physical response and stress response, and also it works within cortisolin and adrenaline glands, neurotransmitters also. So it works on the starfish exercises, like it works with the starfish exercises. So the both the extremities will come into the extensions, and then when they need to close up, it becomes into the flexion. So it gives a simultaneous command to the brain to work on. And then a weight blanket on the body, so it also works with the proprioception. So what happens when the child is being like physically drained and sit, so mentally the brain starts to work, they start focusing, they start sitting, so there will be a cut for the diversional attention, rather they have the sustainable and the proper attention toward a task. And also a breathing, when the breathing is being done, the trigeminal cranial nerves will work on. So there are different kinds of breathing styles where it can be integrated the trigeminal nerves to like work on, so that it brings the inner peace, so that it develops the unique cognitive motor skills in the children. And also we can give like a gentle swinging, like that kinds of activities. And then it's TLR integration activities. So TLR is nothing but tonic labyrinth reflex, so it works on core strengthen and the balance, like as I told, ATNR works in the cross body coordinations, and Moro for emotions, and TLR for the core strength and balance. So here we have, so it's deals with the body. So how the body needs to work, how we push the child to work the core strengthening, because all the parents would have heard this term very frequently, like core strengthening. Why? Because it integrates the TLR. So it's the first one, it's going to be the Superman pose. So the Superman pose, what's happened when the style extend and lift up the body, so both the upper extremity and lower extremity come into the extensions, so that it gives them the core strengthening for the abdomen, so it starts working. And also like a prone swinging, reaching the down game. So when the child is being put into a small swing, so there is like the gentle rocking, and also and moving or stoking. And when the activity is being done, there is again the posture, you see the full extension of the body. And the log roll, when the child does this, there is an extension and the proprioception is in the action. So next is the STNR integration activity. So it works on the cat cow yoga poses or rocking on hands and knees. Like for example, the child it's been in the quadruped. The first image is the child, it's been in the quadruped position, so with a gentle rocking and that kind of stoking, like the child will be like integrated, and the child starts to work, and also the child receives the egg stability, and also it looks forward towards the activity and focus. Then the donkey kick, what happens, the whole upper extremity, it's in the action that they weight, the weight transmission is being done. And when the body from the abdomen it's being lift up for the kick on the lower extremity, it's like make it's tuned the child into the action, and the reflexes start integrating. And then when the child does this obstacle course in the lower crawling under this lower obstacle courses, so it helps them to focuses with their all the both the hands and the both the legs, like how to do it, like it involves the problem solving, as well as like how to come out judgmental, and it makes the child to integrate, and also it works on the side of cognitive. So everything, it's an interchange, and it's an interconnection with one another. And then the spinal gland integration activities, so it works on the trunk control and the sitting tolerance. So here we go. So the first one is like belly crawling, making the child to move with the belly crawling, so that it helps them to integrate the spinal gland. And trunk rotation with the music, so what happened, the pelvic and the legs, the lower extremity will be in a stable portion. So when the trunk is being moved up, so the child with the music, so it's been aligned, so the auditory and the vestibular, it's in the action, and the alignment, it's been with the spinal gland, because it touches the lumbar region. So we need to stabilize the trunk. When the trunk is not being stabilized, it affects the posture. If the posture is going to be affected, how come the child writes on a table? When the child is unable to write on the table, how come it works on the handwriting? So everything is a span, it's a chain span. So one is not being corrected up, the other has a delay, and the other goes on to the delay. So when we give like this trunk rotation with the music, so it helps a lot. And also a weighted blanket suit, when we can when the child wants to keep on moving, we can give this kinds of proprioceptive activities to give the deep pressure stimulations, so it makes the child to uh, calm, and also it integrates what the child wants, and also it makes them to do the work, so the brain becomes a calmer, and it does them to be do the other works and to concentrate more. So this is according to the American Occupational Therapy Organization. They have been given this anti-gravity position, so that this helps in all the reflex like to work on, and which will integrate when the supine flexion. So when a flexion, the flexion is being done at the age of 4, there is a length of time, like it's when the child is having 10 seconds of doing this supine flexion, it gives them integrated of the reflex. When it's 5 years, it's going to be 25 seconds of integrating. When it's 6, so this kinds of integration, anti-gravity integration, helps them to integrate the reflex they need, and also the prone extensions. So when the child is being doing this prone extension with the age of, there is a category, different categories of the age and different length of the time for the particular categories. And also, so the after this, the main thing what we need to be like have a knowledge, like little more knowledge of this is how a primitive reflect integration exercise help with an autism and ADHD and all the other neurodevelopmental, like especially it works with motor skills and postural skills, attention, eye and coordinations, visual spatial skills or oculomotor skills, balance, grossing the midlines, handwriting, math, and reading. So when you analyze, when you've been like analyzing and like standardizing and making a strategy, when you see all these things, as we saw like before in all the in all the PowerPoint slides, everything is linked with one or the other reflexes. So when this reflexes start integrating are into the action, we can see an improvement in all the categories that we need. Either it can be an academic, or it can be in the gross, or it can be in the fine, or it can be in the movements, balance, anything. And the importance of the primitive reflex is that it has the foundation of our nervous system. So without that, like, it's the head of that. So we need to compulsory work on that. Without working or like touching into it, we cannot move out. So that it's the base thing. It's when we are setting a building, we need to make the foundation, the base, then only we can reach into the topmost building. So like that. So this primitive reflex, it's need to be in a proper integrated, and it need to be in a proper action. So why uses a reflex exercise for the ADHD or an autism? So especially we see in autism or in ADHD, like ATNR plays a vital role, and also it impacts on like balance and crossing the midlines, poor handwriting. So everywhere, whatever we need, every treasure is inside this reflex. When this hidden treasure is being founded out and it's been started to work up, we can find the golds and the silvers and the gem that's been coming out from our children's. And also, so the major reflex integration exercises that has been improving in the neurodevelopmental is like Moro reflex exercise is open and close exercises, marching in a place. So it helps us in the ATNR, zombie walks, silly crawls, ATNR, and backward silly crawls, Superman's meatball exercises. So like marching in the same places, it helps, it works like a cross crawl activity, and sliding up and the meatball exercises, so that it works on the trunk shifting. And also this extensions works in the ATNR, STNR, and the TLR. So all it's in the same action. So next, to the advanced technology. What is the innovative technology intervention that can be done in the primitive reflex area? So first is we are the virtual reality or gamifications, auditory and the bone conduction devices, 3D motion analysis, and robotic exoskeleton assistance. So here as a team, we work with this with a virtual reality. We work for the kids, and we give them a different kinds of activities and the integration stimuli with a VR. And then we does an advanced assessment and research tools that has been happening up. And we does the nanotechnology, tiny sensor, digital integration program, and neuro emerging evidence. So as a team, we does this neurofeedback and the neuro emerging. So this, as you see in the image, the child will be having a brain mapping mask. So this brain mapping mask will work in the different sectors of the neurotransmitter. For example, we have a different sectors like alpha, theta, beta, gamma. We have a different and other we have this kinds of neurotransmitters are working. For example, GABA works for the hyperactivation, and the alpha works for the sleep. So this kinds of delta, we have delta sometimes work with the sleeping motors. And this kinds of the brain emerging, the neuro emerging, it works for the child to attend the focus. And also you can see the child is being given up the to draw the infinity 8 activities. So it's also integrating the ATNR, and also it is also developing the child to focus, like how it works. So there is a neuroimaging and a mapping, so that it tells how much level it's been like integrated of the child to explore and what is being needed. So the concentration and developing will be a lot more. And also this is like with a sensory and a forebrain, and also again with the neuro imaging devices. So this is another type of a different cap. It also works with an A1 T1 and like a F1. For example, F1 is going to be the frontal lobe. T1 is going to be a temporal lobe, and we have a different kinds of coding. So when this it's been like placed on this particular part of the brain, it stimulates the lobes, it stimulates the different lobes, temporal, occipital, parietal lobe, and the temporal lobe, and the frontal lobe, because frontal lobes plays a vital role. So when this neuro imaging is being done, the child gets like stimulated, it starts working even externally and also internally of the child, and we can see a lot more productivity from the child. And also the headphones, it's not a normal headphones, it's a sensory based. So the sensory based, it's another protocol, it's been like tuned up according with the music that enhances the auditory canals, the auditory reflexes, and the vestibular part. So it works on the inner ears and the eardrum or the cochlea. So it works, it makes the child to enhance, it provides the calm inside the aroma inside the child, so that it makes the child to wake up and also work towards the productivity. So it's been a hand on hand. And then, nothing, last but not the least, this is an astronaut reflex integration. So nowadays, everyone like been very familiarized. What is an astronaut reflex? Astronaut reflex integration is nothing but it's an astronaut training protocol. So it works on, especially like some would have seen the images, some would have seen something videos that's been upcoming in Instas or social medias or YouTube like that. But what is the background of astronaut reflex integration? It's a sensory based integration, works to improve the brain process movement, balance, and vision and the sound, like visual perceptuals and the sound. So it also focuses on the strengthening of three sensory keys. For example, sensory systems like vestibular system, visual system, and auditory system. So it works, what it helps to improve. So when a child it undergoes an astronaut reflex, so what are the improvement they get, or what is the benefit they get, what is the input they get, so that they can bring out the output colorfully. So first one is going to be the attention and the focus, and then it's a body awareness and the postural control and the bilateral coordination, reading and the visual tracking, emotional regulation, and motor planning. So all this factors will be improved through to the astronaut reflex. And this the thing as a team we does like this is the astronaut board. So we have a specialized like music, so we does in the supine position and in the sitting position, and also ocular oscillation movement, so that it helps the child to regulate the vestibular, the auditory, and the vision and the visual perceptual systems also. So it works well. And so, okay, before going to the question, so I would like to thank uh, my head, Dr. Ragida, for giving me this wonderful opportunity and making me so like a bold to like give me a platform of exploring me, and also I'm so grateful for TDCC for giving me the opportunity, and also for all the audience, like each and everybody that's been like very patient and listening for the primitive reflexes. Primitive reflexes, it's not like a just a small one, it's a full of clinical based topic, but there is a many hidden treasure in that, so that it needs to be worked. When it's keep on working, it gives them a productivity. And also I would have let us move into this question session. So I have seen few questions, and I would like to give my answers towards start the enlightenment of it. So especially, so many parents have the doubt: what is OT? OT is not like n- uh, it's not like a easy thing, it's like a peaceful, and it's a more creative job. It's OT is an occupational therapy. So what is occupational therapist does? Because many have a confusion that what a physiotherapist does, what a speech does, and but what OT does. OT, we make the children's more independent and we work for their activity of daily living. So activity of daily living is that we have a different component, either it be like in a play, it can be in an academic, it can be in the eating, it can be in the dressing, ADL. We have a ADL, IADL, ADL. We have many components to be worked out. We train the children in a functional way so that they can come out in a flying colors in their academics and in their family, in the social and in the environment. So we make the child to be like people, environmental, occupational persons. So we make them to be like interlinked, interconnected with the environment. That was the OT does. We use many holistic approaches to bring them and work with them a lot. And also we go through the limit, we go beyond our limit to bring them in the flying colors. So that's what OT is. And also the major things that the other question has been very highlighted is that why the child is being like not writing, sitting, everything, because it's need to be integrated with ATNR, STNR. So especially ATNR, when it's been like integrated a lot, you can see more academics improvement in the child. So thank you for this opportunity. There is anybody who want to ask any questions? The last question, or I would hand over to the team.
Thank you, Dr. Ragida and Emmy, for the informative session. Thank you, everyone, for joining us here today and on YouTube Live. We appreciate your time and participation. See you next month for the next webinar. Thank you.
Thank you. Thank you. Thank you, Emmy.
Thank you.
Thank you, Dr. Regida.
Welcome.
Thank you, everyone.
Thank
Thank
you.
you, Doctor.
Bye-bye.
Thank you, Amy.